This podcast provides general information, not a substitute for professional medical advice. Please consult your physician for personalized guidance.
Hello, welcome back to Psych Rounds, a resident-run educational psychiatry podcast. I'm Dr. Larry Wang, and I'm joined by my co-hosts, Dr. Tanner Hewitt and Dr. Bradley Miller, and today we have a very special guest on our podcast, Dr. Lorrie Garces. She's currently a consult and liaison psychiatrist with Central Michigan University and is the recent recipient of the Department Faculty Teaching Award. She completed her general psychiatry residency and community psychiatry fellowship at the University of Florida, where she also received her master's in public health. She's a book lover, a sports enthusiast, and somehow managed to balance her professional life with the many extracurricular activities of her family. So, anything else you wanted to say to introduce yourself, Dr. Garces?
No, not at this time. Thanks. The introduction was very kind, and it's great to be here.
All right, so since she's a CL psychiatrist, we thought we'd do an episode on delirium, which is definitely one of the most common consults you'll get on service. So I think the most basic thing to start off by asking is, what is delirium? Because from what I understand, this is a very, very general term. Delirium can be secondary to many causes and can present very differently among individual patients. And interestingly, the National Institute on Aging has described it as acute brain failure. And I was wondering if you agreed with this description or not.
Yeah, I think this is a great place to start. I mean, as it turns out, there are a lot of terms that are used to describe what we would call an acute disturbance in cognition, which is really what we're talking about with delirium. Some of those terms beyond delirium are things like encephalopathy, acute confusional state, acute brain dysfunction, acute brain failure, like you mentioned, and altered mental status. In the hospital, on a psychiatric consult service, the terms you're probably going to see the most often are encephalopathy and altered mental status, sometimes followed by delirium. But there's very little evidence to suggest that there is much difference clinically between these terms and how they're used, and they all refer to basically the same type of clinical picture that we define as delirium in the DSM-5. And so by that definition, delirium is an acute disturbance in attention and cognition that is not a result of a neurocognitive disorder and is directly explained by a medical condition.
So, Dr. Garces, I'm going to jump in here for a second. What are actually the most common causes of delirium? And why does it happen in the medical hospital so frequently? So for reference for our audience, estimates of the rates of delirium in the medical hospital are as high as 30%. And this number jumps up in elderly patients as well as patients in the ICU.
Okay, yeah, there are so many causes, and a lot of times, we're really probably not talking about one cause. But some of the things that you want to be aware of are things like strokes, infection, any sort of medication-related complications, and that can be too much of a medication or maybe a sudden withdrawal from a medication, thyroid conditions, cancer, heart conditions, pneumonia, urinary tract infections. I mean, there's a lot of things going in the hospital that can lead to a picture that looks like delirium. So the way that this is kind of thought about is that most cases of delirium, the etiology is probably multifactorial rather than one cause. And the model for thinking about this is thinking about both predisposing factors and precipitating factors. So when we think about those two things separately, predisposing factors might indicate a patient's level of vulnerability for developing delirium. For an example, we might think of a patient's baseline neurocognitive status, and somebody who has a moderate or even severe dementia picture may be much more vulnerable to delirium than someone who doesn't. And then in addition, we think of precipitating factors, and these occur at different levels of severity. So, a mild infection versus sepsis or something like that. And then we put this all together and we realize that there's a lot of different factors involved in how a delirium might develop. So the groups of patients that you're discussing, elderly patients or ICU patients, these patients are just likely to have a higher vulnerability and potentially even more severe precipitating factors.
And Dr. Garces, I just wanted to jump in because Dr. Wang did include this in our show notes for today's episode, but there's a great Carlott psychiatry reference table. And I'm just going to read some of the predisposing factors that are on it here. So for predisposing, we see multiple medical comorbidities, older patients greater than 65 years old, polypharmacy, poor nutrition or hydration status, pre-existing cognitive impairments, and sensory impairments like hearing or vision loss. For the precipitating factors, we see things like alcohol or drug withdrawal, medications, pain, sleep deprivation, severe illness, surgery, and urinary retention. Would you agree with these, Dr. Garces?
Yeah, that sounds like a great chart.
Now that we've covered risk factors, let's talk now about diagnosis and interview. So what questions should you generally ask, and what should you observe, and what screening tools do you use when evaluating delirium? I personally have found using the clock drawing test to be very helpful due to its speed. It's pretty quick to do, and I don't want to say never, but very, very rarely have I ever seen a delirious patient be able to complete this test accurately. And I also tend to like it because you can test multiple things like attention, memory, visuospatial ability, and executive function. But do you have other recommendations here?
Yeah, sure. So I think a lot of different cognitive screening tools can be useful, but you'll often sort of uncover a suspiciousness for delirium when you just start by asking the patient to explain how they ended up in the hospital. And when you're doing that, if there are evident cognitive concerns with the patient's explanation, for example, they might have difficulty with memory or difficulty sustaining attention long enough to answer the question. Also, you might find that they're repeating themselves or having difficulty focusing. That can provide some initial concern. Some of the screening tools like an MMSE, a mini mental status exam, or the MOCA or the Montreal Cognitive Assessment, these are maybe going to be almost too complicated for someone with delirium to complete. And so there are some shorter, more efficient screening tools that can be used for assessing delirium. One of the quickest, most efficient screening tools is the 4AT or the 4A's test. So you're just thinking of these 4A words. That's all you have to remember. The first one is to assess for alertness. The second A is the abbreviated mental test, which is usually assessing the patient's orientation. The third A is to test for attention. In the 4A test, specifically, they use like naming the 12 months backwards. So starting with December and naming them off. And then the fourth A is acute presentation. One thing that I want to note in that regard in terms of testing attention is that a common error that I see with students or interns when they're first learning some of these screening tools is that they think some of these things are related like to calculation or like how the patient is accomplishing the task. But really, an attention screen is just to see whether a patient can sustain attention for a longer period, longer duration. So what I'm saying is Serial 7s, for example, that is a screening tool for attention. And sometimes I will see a student start that screen by saying, okay, I would like you to start at 100 and subtract 7. And then the patient will say 93. And they'll say, okay, great. Now from 93, subtract another 7. And so that really defeats the purpose of the screen. When you're doing a screen like that, you really need to start and say, okay, I'm going to have you complete this activity. I'd like you to start at 100 and count backwards by 7, and then just let it go and see what the person is able to do. Similarly, in the 4A's test, you would say, I'm going to have you start at December and name the months backwards and let it go. And whatever they're able to do is what they're able to do. So finally, another screening tool for delirium that takes a slightly different approach, but is easy to do and easy to remember, is the simple question for easy evaluation of consciousness, which is abbreviated as QEEC. And that just involves asking a patient to name somewhere they want to go that they haven't been to before. And then when they're able to identify that location, ask them how they would go about getting there. It sort of requires putting several tasks together and is a good indicator of potential delirium symptoms.
So I want to get into some of the nitty-gritty details here. So it's thought that there are different subtypes of delirium, including hypoactive, hyperactive, and mixed delirium. So how do we distinguish hyperactive delirium from like an acute psychotic break or an acute manic episode? And what about hypoactive delirium from depression or even catatonia?
Yeah, that's a lot of questions, and that kind of emphasizes how confusing this whole diagnosis process can be, especially when you're meeting someone for the first time and you really don't know what their cognitive baseline is. And my standard answer is always that collateral is going to be one of your most helpful tools. If there are family that know this patient well, or maybe their past, medical history, you can find out, do they even have a significant past psychiatric history? Sometimes you will get a psychiatric consult for psychosis, and then, you'll start doing a chart review and you'll see, this is a 60-year-old patient who has never had psychosis before in their life. And that, of course, is a, indicator that you might be dealing with something other than a psychiatric diagnosis. But you're also looking for things like, has there been a recent medical event? Has the patient had a history of catatonia? Timeline is important. Has the family noticed a history of cognitive decline over a gradual period of time, or is this something that was happening slowly and now is happening quickly? All of these symptoms that you're talking about, you can see disorganized thinking, psychotic symptoms, rapid speech. You can see any of that in a hyperactive delirium. So you really do have to use some of this collateral and chart review to help you. Hypoactive delirium, however, that is harder, I think, because that's when a patient is having very limited to no interaction with their environment. And it's probably the category that's identified the least often. So it's much easier to catch a hyperactive delirium because the patient is agitated and may be causing behavioral disturbances in hospital for. But the hypoactive deliriums tend to go missed often.
Yeah, I think that's a really good clarification of the different types. Is there any sort of idea? I know you mentioned that hypoactive is frequently missed, but is there an idea of whether hypoactive or mixed is most common, or does it seem to be about equal, or is this not clear?
I think, this is probably one of those questions where reporting error is going to be a kind of a confounding issue. You are going to catch so many more cases of hyperactive and probably mixed as a result of it partially having waxing and waning hyperactive symptoms, than you are hypoactive. So I'm not, I think that when you kind of look it up, it's always listed as suspicious that there are many more cases of hypoactive than are being identified. But if you're just talking about which cases are getting identified more, it's definitely hyperactive and mixed.
Yeah, thanks, Dr. Garces. So I want to also approach a question that's very frequent in med school that I encountered, and even now is likely going to be a great refresher for myself and many, but what is the distinction between delirium and dementia? And we get practice questions all the time about this, trying to distinguish chronicity, but how would you best identify this, and can you have both?
So you can definitely have both. And what you're really looking for to distinguish the two is just the overall timeline. So in the case of dementia, the onset is gradual, and at least initially, you don't have that marked impairment with attention and concentration. Delirium, the onset is acute, and you're going to sort of immediately notice that the patient's ability to sustain attention and concentration is really impaired. That's your best distinguisher.
I know, as a student as well, just a quick follow-up question. One of the things that I sort of was taught was the biggest distinguisher, or maybe a component, was that delirium is always fluctuating. Is that actually accurate, or is this more nuanced? Can we rely on that in clinical practice to actually help distinguish?
Yeah, I mean, that's definitely a distinguisher. And I think that's what I'm talking about really when I'm talking about attention, and ability to sort of sustain attention. But you do hear that term a lot, like waxing and waning mental status, which is not that you can't have some fluctuations in cognitive ability with dementia, but this is going to be the type of thing where in the hospital, nursing staff or part of the staff might go interact with the patient, and the patient is maybe alert and oriented ×3 and interacting, and then maybe the consulting team goes there an hour and a half later, and the patient is struggling to answer a single question and is maybe alert and oriented ×1. And so putting that all together in the chart and talking with other people who are interacting with the patient will also give you a lot of information.
So I now want to ask you about the importance of the sleep-wake cycle, or circadian rhythm, in the pathogenesis of delirium. Because when I was in med school, and I'm sure when we were all in med school, we were taught that delirium is something that often worsens at nighttime. So why is this?
Delirium definitely can worsen at night. And I think that's largely because those few environmental cues that the patient is relying on during the day that may help to orient them, those go away. And so the environment becomes more confusing and the confusion can worsen. Paying attention to the sleep-wake cycle is an example of an important non-pharmacological treatment, and it's definitely a starting point for addressing delirium. Paying attention to the sleep-wake cycle can be as simple as just making sure that the curtains are open in a hospital room during the day, and that efforts are made to orient the patient to day and night. Family can certainly help with that, and staff can help with that too.
So this is a good segue into talking about some of the treatments for delirium. And I feel like as we go through our training, it's very easy to throw medications at delirious patients, but guidelines generally recommend against medication-based treatments. And rather that you should do non-pharmacological treatments first. So I was wondering, Dr. Garces, if you could talk a little bit about some of these treatments.
Sure. So in addition to paying attention to the sleep-wake cycle, like we just mentioned, most of the non-pharmacological interventions are going to be things that are ideally and hopefully already being done as appropriate patient care. These are things such as optimizing the patient's participation with physical therapy, encouraging them to be as mobile as they are able. You also want to address any visual or auditory impairment, making sure that the patient has their glasses or their hearing aids. You want to reorient the patient as able. This seems really simple, but it's important. So if you ask a patient orientation questions and they answer every one of them incorrectly, make sure that you repeat back to them like that you heard what they said, but you want to make sure that they know what the correct date and location are so that they are able to reorient. Having family interaction at bedside, or even just family photos or photos of things that the patient is familiar with, is helpful. You want to make sure that you've addressed any pain concerns, and you want to, in general, avoid excessive sensory stimulation. So there are always going to be situations where safety for the patient requires something maybe like restraints, especially in the ICU, where someone who is confused or agitated might attempt to pull lines. But in general, it's best to avoid use of restraints and to try to use the least restrictive elements of care.
And Dr. Garces, I want to rely a little bit more on your anecdotal experience and expertise for this question. But how often in your career do you see that these non-pharmacological based treatments work? Or does it kind of teeter on the line where we always progress towards having to prescribe a medication for delirium?
No, I think it's really interesting. They work a lot if you give them the opportunity to work. So on the consult service, sometimes we'll see situations where for whatever number of reasons, it's just not a good idea to use medications. And in a couple situations, we've asked if nursing staff can move a patient to a room where they're closer to a window or might be able to get more daylight. And seen situations several times where that itself has just optimized the patient's treatment. There is a lot of literature out there suggesting that, when patients have family bedside and family is able to reorient in that way, that it's, those are more successful treatment situations. So definitely, if these are treatment options that, can be utilized in the environment that the patient is in, definitely give them a shot.
And then moving now, talking from just the general treatments into possible medications and other things, we're taught in general that we should always be treating the underlying cause in delirious patients as well. If you think it's secondary to infection, be sure to treat the infection. If it's secondary to alcohol withdrawal, treat the alcohol withdrawal, and so on. But let's say this isn't working fast enough and the patient starts pulling out lines and becomes agitated, maybe attempting to leave AMA. What should we do next? Should we then medicate?
Right. So if the interventions involved with the least restrictive care are not working, sometimes medications do come into play. And because we're usually talking about symptoms like psychosis and agitation, antipsychotics are definitely the medications most commonly discussed. At this time, there is not a lot of support from the medical literature for any benefit from the use of antipsychotics. And of course, this category of medication also has risks such as sedation, extrapyramidal side effects, and cardiotoxicity. So if we use antipsychotics such as haloperidol, quetiapine, or olanzapine, we use them with awareness of the risks and benefits, and only in situations where psychotic symptoms might be causing distress or symptoms in general are causing concerns for safety to the patient or others. As a general rule, we try to use the lowest effective dose for the shortest amount of time, and, when possible, also with careful discussion with family. So for patients who are prone to delirium with a hospitalization, it's really important to find out from family about what has worked or not worked in the past, and make sure that information is documented to help avoid redundant use of higher risk interventions that may have low benefit. For example, a family member might tell you that their loved one always has psychotic symptoms whenever they have a urinary tract infection, and that sometimes those symptoms, have created safety concerns. And they will probably know from previous hospitalizations whether it seems that haloperidol has been helpful with the agitation or it's another medication that's helped. So getting that into the medical chart and kind of paving a road for the next person who encounters that situation can be helpful.
Yeah, that makes sense. And circling back to when we were talking about subtypes, including hypoactive versus hyperactive, does this inform treatment at all in this capacity? Like, are different medications utilized or different interventions better for treating these two different subtypes, or does it all tend to blend together?
Yeah, that's a good question. I mean, I think that really medications almost only come up with hyperactive and mixed. Again, the patient who has a hypoactive delirium is the patient who is sort of quote unquote easy for nursing staff, and everyone is just rounding on and treating the underlying medical condition. And there really aren't any specified medications for delirium at all. So there really aren't any specified medications for any of the subtypes.
I also want to ask a follow-up question, Dr. Garces. So you mentioned a couple by name, but do you have a preferred antipsychotic? That's number one. Number two, are you concerned at all about the anticholinergic effects of things like olanzapine and quetiapine? Because hypothetically, this could worsen the delirium.
Right. So I think in general, we just use Haldol unless there's reasons that we shouldn't, and that would be, based on the patient's individual medical situation. There are sometimes reasons why we can't use Haldol, and then if we aren't, then we might try other things like olanzapine or quetiapine. Sometimes it seems like patients who are already experiencing delirium, a hyperactive delirium with agitation, sometimes they will not respond to olanzapine. And I think instead of just using more and more olanzapine, we need to be aware of the idea that we might just need to try a different medication. But interestingly, I believe that quetiapine is the only one of the antipsychotics that actually has a positive outcome in a study, and I'm pretty sure it was in treatment of ICU delirium. But so it's kind of interesting that of all the different studies that have been done, everything has either been neutral or no effect, and quetiapine is the only one that had just a very limited effect in a very small study.
Yeah, and I find that really interesting because we also tend to use very low doses of quetiapine, and at those very low doses, it's mainly an antihistaminergic agent, basically no D2 blockade. So I find that really interesting, really interesting, actually.
Right, and I think if I'm remembering, the study is pretty small, and so it would just need to be replicated. Why is that? Was it some sort of sedative effect for that particular population? I'm not sure, but.
So let's switch gears a little bit and talk about some of the treatments in disordered sleep that we commonly see in delirium. So I've seen medications like melatonin, Ramelteon, trazodone. But what about benzodiazepines? Can these calm patients down and help them regulate their sleep-wake cycle?
As a general rule, we want to avoid using benzodiazepines in cases where we suspect delirium. This category of medication can cause further cognitive clouding, it can cause sedation, it can prolong delirium, even make it worse. So even as tempting as it might be to think that this is going to help acute agitation, we want to try using non-pharmacological interventions or other medications if able.
I do want to comment. It does get tricky because Dr. Garces, when we were on the unit doing consults together, there was a couple of cases where we were wondering whether or not it was hypoactive delirium or catatonia. And it became tricky because the first line treatment for catatonia is benzos. So just trying to say that the waters can get murky sometimes.
It can. And I think, again, this is where you just really have to be paying attention to the medical picture, right? If it's a hypoactive delirium, there should be an underlying medical cause for it. And that's what you're ruling out. And kind of assuming that's what it is, unless, you no longer can find the medical cause. And if you know that a patient from your collateral has a history of psychiatric symptoms and maybe even has a history of catatonia, it's definitely going to lean you more in a direction to try that intervention. I think it's a good point.
So the waters are always murky is what it sounds like. But
yeah, when you're looking at delirium, waters are always murky.
So what other pharmacologic treatment options are available or being investigated besides antipsychotics? So for the preparation for the episode, we've seen evidence for medications like clonidine or Catapres and valproic acid or Depakote. And I know Dr. Wang has mentioned some evidence for dexmedetomidine or Precedex.
Right. So there's some research that's been done with everything that you named, including melatonin and Ramelteon. And the results are all somewhat limited and in general didn't show any specific effect on delirium. The only one of the medications that you named that seems potentially beneficial, especially in refractory and difficult ICU settings, is Precedex. So I should also clarify that the studies have been done both from the angle of treating delirium and prevention of delirium. So when people are looking at these medication interventions, they're really looking at both sides, and all of them have limited results.
Awesome. That's a very good clarification. I feel like it would be remiss if we didn't at least comment on alcohol or substance withdrawal or intoxication delirium. The DSM practically goes into like more detail in that regard, separate from the other subtypes of delirium. This could probably be a whole episode in itself, but I was wondering if you wanted to give any major pearls or wisdom about these in particular that might differ from the rest of delirium.
No, I mean, it was funny when I was thinking about this episode ahead of time, I was thinking that maybe you all should just do an episode that leans itself that way, because I think you're right. There's so much that you can talk about. Obviously, just, when you are evaluating somebody for delirium, just keep in mind that it could be acute alcohol withdrawal and that you would need to use benzodiazepines, right? That would be the one situation where that would be a really crucial decision. And I think without going into further detail, that's probably the easiest point to make.
All right. So I wanted to ask you, Dr. Garces, any last points you wanted to touch on before we close up this episode?
Yeah, I just wanted to briefly mention that there's been a lot of recent attention drawn to a patient's subjective experience of their delirium symptoms. We often think of delirium in the active treatment mode, but it's really important to remember that a lot of patients are able to recall portions of a delirium episode later, and it is both extremely distressing and traumatic. So having awareness of this possibility and considering it both when the patient is in the hospital immediately recovering from delirium or when you're completing an intake, maybe at a separate time that involves a patient who might have had past episodes of delirium, it can be really important to keep that traumatic element of it in mind, especially in understanding the patient's past subjective experience with illness. And then finally, I wanted to emphasize that really the reason that we're all talking about this is because there is a much higher rate of mortality for patients in the hospital who experience delirium. So picking up on those symptoms as early as we can and using the multiple screening tools that continue to be developed, evaluated, and utilized is a really important part of all of our clinical practice, but especially the consult team.
All right, so that brings today's episode to a close. I want to thank Dr. Lorrie Garces again, our content expert for today's episode, for coming on the podcast and discussing with us a very important topic, something you are all but guaranteed to encounter as a medical student, a resident, or just really anyone in the field of medicine. As always, to our listeners, feel free to contact us at psychroundspodcast@gmail.com. You can send us questions. You can also send us episode suggestions or requests. We would love to hear from you. Also, if you're a fan of the podcast, please drop us a review or send us a follow. Thank you again, everyone, for listening as always. And another special thanks to Dr. Lorrie Garces. We will see you next time and have a great weekend.